go. Okay, it's my pleasure to introduce Rebekah Cook. Rebekah, as I said, is our clinical nutrition director here at Center for Change. She's just a lovely human, and we're so happy to have her. She's been at the center off and on for a lot of years, and we're so happy to have her back with us. Rebekah helped launch the intuitive eating program at Center for Change, Clearback, I think in 1998. Does that sound right, Rebekah? Something like that. It's been a long time. And we became a certified as a gluten-free safe spot at Center for Change this year, which means that we can make sure that we can help those patients who have a gluten intolerance or a gluten allergy or celiac. So that took a significant amount of work, and Rebekah really led the team to be able to get that certification. On top of that, she's a kind person and treats our patients with such dignity and respect in a place where it's really challenging for them. Food is a really hard thing for them, and Rebekah always treats that with such kindness and respect. So I'm just so pleased to have Rebekah here with us today. Rebekah, I'm ready to turn it over to you. Will you share your screen, please, before I hop off, and we'll make sure we're good to go?
Yep.
Thank you.
Okay.
Great. I see it. You're good to go. I'm going to turn off my camera and my mic, but if you need me, holler, I'll pop back up. Otherwise, I'll see you at the end of your presentation for questions, and we'll go from there.
Okay, thank you. So what we're going to talk about today is moving from fear to freedom. So there are different nutrition interventions that you can use when you work with your patients. And we'll kind of just get going with it. I'll kind of add a little bit as we continue to talk about this topic, to kind of so you'll understand the background and why certain interventions might be helpful. But some of our objectives, the first one is we want to be able to have everybody be able to know how to initiate nutrition interventions, how to implement the intervention, how to assist with mood regulation if that's needed, and process the intervention with the client. So you will want to also have participants be able to explain one intervention used with clients who are restricting their food intake and how to help them decrease their anxiety and also sometimes resistance during the intervention. And we also want everyone to be able to describe a nutrition intervention that can be used with someone who has difficulty stopping eating, and then also how to process that as well. Okay, so one of the reasons we kind of put this slide up is because as far as nutrition interventions are concerned, dietitians have historically done interventions, and the reason we've done that is that's kind of the role we've been put into. We are skilled at educating patients about medical concerns, and those patients who require special diets, tube feeding patients, community education, and also managing food service institutions. But our degree is more of a pre-med degree with additional chemistry management and nutrition coursework. So it's not necessarily therapeutic, and there's a lot that's kind of we're coming out of college or out of the internship not knowing. We're not trained to work with fear, anxiety, or other mental health conditions. And so, I've talked to different therapists here, different clinicians about how it's totally appropriate for other clinicians to also do nutrition interventions. It really does not have to be a dietitian who does these. A lot of other mental health clinicians may be more skilled at dealing with some of these fears. However, I'm actually getting my master's in marriage and family therapy and done with the coursework now. And I also do know that even though you got a lot of schooling as far as with therapy wise, having everybody kind of gets out of school without some of the knowledge that they need or experience they need in order to treat patients right out of the gate. So we'll talk about some of those things. So therapists can totally help clients work with fear and anxiety. They're probably more so qualified to do food interventions with patients with eating disorders, since the problem's not necessarily nutritionally based, it is a fear-based issue. And so I just want everybody to feel like, hey, you guys are just, you have enough background and education to also do nutrition interventions with patients. All right. Some of the reasons we want to do these is because it's an active intervention. We can talk all we want about ideas of what to do and educating patients on different things. But unless we're actually doing an intervention where they can have a different experience of food and a different experience in their body, sometimes it's all just way too heady. We also can help clients work through fear while being in a distressing situation. So that distressing situation could be the food itself. It could be the place that person is. It could be it could be the environment that somebody's in with food that makes things more difficult, but it's really helping them in the moment. And we also can provide clients with support in those challenging food situations, talk them through things, they have a different experience, they'll be way more likely to have some confidence in their ability to approach these situations outside of a treatment setting or outside of your office. And as I mentioned, yes, they'll gain more confidence. Okay. So as far as with research and nutrition interventions, a lot of what we'll see is that it has to do more with, family-based treatment, meal support interventions. So it is supporting the patient in a food environment, but it may just kind of end there. There may not be as much depth to that experience. So we're going to talk about some experiences that may not be in, researched right now, but they're ones that are very helpful for patients. Compassion-focused therapy, it really has to do more with finding out like what the patient wants, how they want recovery to be, what's important to them. So, I am all for that all the time, like collaborative care, absolutely. There is one study on imagery, and then also mantra. Mantra is more of it's more with adult people who have anorexia, and for more of the Maudsley hospital. So that's what that is. So there's not a lot of information or articles out there as far as with nutrition interventions, specifically that we're going to talk about. And yes, I've done this work for about 25 years now. And a lot of these interventions were ones that were made up because patients or clients said, I need help. And so I was able to kind of start doing these. We still do a lot of these at the center now, but they're mainly client led and or just from the needs of those clients. So the first kind of topic we'll talk about is kind of allowing a patient allowing themselves to live and take up resources. So at times you'll have patients who will they'll kind of want to get away with doing the least amount possible, or say like, if they don't put butter on their bread because it's not really needed, you can do without. It's things you can do without. So one of the most basic, and it's not necessarily basic, but it's not done with food in your mouth, it's done more with eating in your head. And it's covert behavior rehearsal. Now, I had a patient once who had superior mesenteric artery syndrome, and that is where that artery kind of squishes back on the esophagus, or there's a lot of pain because the fat pad is diminished. And so you're tube fed, and they're tube fed for a fair amount of time until the fat pad gets bigger. And this patient just imagined themselves eating because they couldn't actually eat real food, but they had 6 weeks of tube feeding. And they really just, I think they were just so fearful or so upset that they were now getting tube fed, that they didn't want to have their eating disorder anymore. And so they started imagining themselves in eating a Mexican at a restaurant, eating the Mexican food, being very, having very vivid images, and then getting through that eating experience and having a great time. And it was a very vivid experience. That's what's very important when it comes to imagery. And when I worked with them, they really didn't have a problem with food. And I was thinking, okay, well, I'm pretty sure this patient's kind of lying about it, or they're purging, or they're doing something. But they explained that, you know, they'd had day after day after day of practicing this imagery, to where it became something that they felt like they had already done. So it's a good way to help patients experience food without actually eating. So they would practice it over and over and over again until they're able to get through an entire eating situation in their mind or imagining it. So there's very little risk because they're not actually eating food. So sometimes patients are more comfortable accepting this when they're not able, they're kind of afraid of doing other things. Now, I had one patient who had a 50-year history of restricting, and then they'd binge and purge at night, kind of wake up in the middle of the night and binge and purge. And they had had some difficult things happen to them when they were a little kid in the middle of the night. So there was a bit of trauma there as well. And I presented this experience to them as a way for them to give themselves more permission to eat in their mind. And what they ended up doing is they would get through that imagery, and then they would go to a park in their head that had pretty lights, and it was a very calming place for them. So in the middle of the night, when they wanted to binge and purge, they would start imagining themselves eating. This was not the intention, but I want you to kind of know that this could be used in different ways. And so they started kind of just eating in the middle of the night in their mind, and then going to the park with the lights. And after a period of time, instead of eating, they would just start imagining the park with the lights, and it was a very calming place. And so they were able to not get up and binge and purge. And they would just go to that place that made them feel better in their head. So there are different ways to kind of think about, okay, I could use imagery in this way or that way. So we want to imagine a different outcome. Now, another thing that you can tell a patient, and these are just very little basic things, but is to plate for someone you love. So at times we'll say, okay, give yourself permission to eat. That could be our intuitive eating thing. We might say eat a main and 2 sides. We might even say eat according to the rule of 3s. There's all these different ways. But if it makes sense to that person, if they were to make a plate for someone they love and they would do it differently, then that would be how we could explain them to plate their food. And we think of this more as like more of a self-worth, self-care way of plating. And at times people are like, well, but I don't really feel like I love myself that much, or I don't feel like I have much self-worth. But it does make sense to some people to explain it that way. A visual item being a statement. Now, this would be something you would do with a patient who ate, like they would eat alone, or they were afraid to show people they're eating. They're afraid of being judged by eating. So it might be having a candy bar wrapper or a bag of chips and putting it out on their desk, or have the that little empty wrapper in their pocket, but it would be a visual item that would be a statement that, hey, it's okay for me to eat. And this can be, it may seem very simple, but it can be very, very challenging for somebody to have a candy bar wrapper in their pocket, especially if they're afraid of what people think of them, and if somebody would judge them for eating. And it might be somebody in a larger body. It may also not be. It's really just depends on the person. Planned permission to eat. Sometimes I'll say, okay, we're going to plan a binge. And this would be for someone who has not given themselves permission to eat. But it would be getting all those types of foods they used to like before they had an eating disorder. And really practicing being like, okay, it's okay for me to eat. It's okay for me to like this food, but to kind of give them that permission to eat. And it really might take baby steps. I had one person who was admitted for anorexia, and they told me, oh my gosh, I ate all the Oreos. And I'm like, it is okay. We'll do it again. We'll do it day after day. Totally normal to eat more than you're comfortable with, or you got fuller than you were used to. That's okay. And I went into the kitchen to check how much they'd eaten, and it was one sleeve, one side of Oreos. So they hadn't eaten the whole thing, because I thought, oh, I have to buy more for tomorrow. But their experience of it was too much. It was excessive. I did all of it, but that can be a very helpful thing if you have somebody that you want to help them with giving themselves permission to eat. The next one is more of allowing imperfection and relaxing control. So it's somebody who's more rigid with how they want to do things, but it's eating at times not planned, messing things up. So and it could be breaking rules, challenging perfection. So anything they're like, okay, I have to do this exact, we try to do it a little off. We try to mess it up. And then to be able to be like, I'm okay, everything's okay. So there's a lot of self-talk that has to happen, right? And to know that it's important to allow for to be flexible for life. I mean, that is a super important skill. We want to be able to also challenge the unknown. So to be able to, that's kind of the one thing I really like with the center is, with a lot of our meals, they're not chosen. They are just given. And so the patients have to kind of go in and be like, okay, what am I getting? And kind of make do, be more flexible. And so it's a good experience that they'll have, even though it can be really challenging and stressful for some people. We do have different ways we do things as far as with our patients who have ARFID than we might do with somebody who has more anorexia or bulimia or binge eating disorder. But the challenging the unknown can be really helpful, and to relax control. We want to also allow discomfort. Some of this can be with some of our patients who have ARFID or who have kind of a heightened interoceptive sensations where they sense a lot inside. We might do food and texture exposures. Lots and lots of those are super important. We can do these in outpatient too. We want to help them experience the unknown and unfamiliar, and these are client-led. They're when clients want to try to eat more food, and so we'll do that. Physical discomfort, with one of our dietitians who's done quite a bit of work with patients who have ARFID, it might be where somebody would drink a lot of water in order to experience a fuller filling and to know that they're okay. It could also be to spin themselves around on a chair a lot until they're a little disoriented or don't feel quite right, and be able to sit with that. It could also be with some of our patients who, we just need them to get fuller in order to maintain their weight and to know that this shall pass. I don't have to do anything to get rid of the food or the feeling. It's okay. So to kind of be able to self-soothe, and that is super important. We also want to allow people to experience pleasure and to know it's okay. So this may seem like, well, gosh, yeah, people like to feel pleasure, but for some people, this could feel like a bad thing that they shouldn't be doing. So one of the ways we can do this is to eat food the way it tastes the best. So it would be paying attention to, say, if they're eating a cookie, if this experience would be better if I had milk, to allow themselves to get that milk, and it is just being very more self-aware, and then also to be able to be like, it's okay to have this the best way possible. I don't have to do without. And it is also honoring preferences. One of the ways you can preface this to patients would be, I had one therapist that was a colleague that would always say, how we are with one thing is how we are with everything. And so if that person wants to be able to have pleasure in life, or to be able to be like, it's okay to feel pleasure, one way we can practice that is also with food, to be able to say it's okay to feel pleasure when I eat and to enjoy my food. Blindfold eating is a way to get rid of all of, or at least one sense. So we get rid of the eyes, and this is only if patients want to do this. So if they're really motivated visually, it would be where we would cover the eyes and then more pay attention to taste, texture, their experience of food without that sense. Blindfold eating is not one that I've done very much, but some dietitians do find it helpful. Some therapists do find it helpful as well, right? We can all do this. And we want to experience how senses impact eating. We want to teach patients it's okay to feel comfortable. And that might be by saying no, right? We don't always have to say yes. We don't always have to say yes in life. We don't always have to say yes to food. So saying no and disappointing people is important. This could be for somebody who feels like they have to clean their plate, where they have to accept food if it's given to them. Now, for other people, accepting food when it's offered is an important thing. And for other people, it might be important to say no. No, I'm okay. I'm good. Thank you. Whatever. Also, there's a experience called a therapeutic food day. Now, I created this mostly because I'd have patients who would say, if I have cheesecake, I'll never not want cheesecake. And so what we would do is get a cheesecake or any type of thing and have it. We can have it for breakfast, snack, lunch, snack, until you no longer want it. And it's so that somebody can have the experience of being satisfied of that taste or texture or food without it just being a cognitive possibility. So they need that experience in order to know that, hey, if I give myself permission to eat cheesecake, I'm not always going to want it. Now, they would possibly want it if there's an impending restriction planned or a diet planned, then they may really be more motivated to eat all the cheesecake if they plan on not ever eating it again. And then it also would decrease the novelty for that patient, or if it's special or restricted, people tend to want more of it. We have a great experience that we do with some of our patients who are, it's also cleaning the plate or not wanting, they don't want to waste food. And so you can have your patient overplate food or put a lot of food on or go out to eat, whatever it is, and practice throwing food away, right? They could do it in your office. So they'll bring in a bunch of food and practice, okay, I think I'm done. I think I've had enough, and throwing it away. And so they'll have to kind of, you want to process with them what it is for them to throw food away or to waste food, or what it means to them. What's the bigger picture here when it comes to throwing food away? We also want to help patients feel like it's okay to take care of yourself. So this could be eating in challenging situations and dealing with anxiety. So I'll give you an example of a experience I did once upon a time. So it'd be 25 years ago, right? And it would be, I had some patients who didn't want to eat in a swimming suit. So what we ended up doing was we go to the park and we would eat pizza in swimming suits. And then we'll put our clothes back on and go. So it's and then also I've done one where we've eaten in a gym. So different places that would be like, I can't eat there. Or it is like you go to the gym to work out, you don't go to the gym to eat. So that's why we'd go to the gym to eat. Just to break rules, know that it's okay to do this. You can eat in any situation, it will be all right. And you can kind of find out what their situation is. You can assign it to where they just do it. It may also be like they don't want to eat and wear shorts, or they're terrified of wearing shorts. And then if they're eating, those things tied together, especially if they're worried about their thighs growing, you could totally have them wear shorts, come into your office and eat and process what's going on for them. It works really well. Now, another intervention I made up with permission to eat is more of a solo with food, it's because I had patients who would say, the only reason I'm okay is because you're watching me and you're kind of containing me with food. So, and they would say, well, if I was alone, watch out, I would eat all of my food, or I would never stop. So what we do is we can get a bunch of binge foods, right? And at least in the center, one of the things we'll do is block out all the windows, or like tape over them or whatever, and give them a bunch of binge foods. And they get to stay in there for an hour with those foods. You'd kind of preface it with saying, hey, you don't have to eat all your food. It's not about finishing anything. It's just about experiencing. You can write how you feel. You can come out and ask for help. You can ask them, do you want me to check on you? And sometimes it's repetition that's important. So it could be that solo with food the first time might be a little stressful. And so we want to have more experiences or more times that we kind of repeat it to where they can see like, okay, if I do this more than once, things change. It's not as intense, and it could be just as intense, but it might become less intense the more they do it, and to know that, okay, I'm okay, I will be all right. One of the things I have a younger sister who is a school counselor, and she has a saying that she'll teach her students, and it's, I'm safe, I am brave, I can do this. So I have told patients quite often that that's something they can say, something to really that self-soothing. And we want to help them with the solos with food, learn to trust themselves if they're by themselves. So another one, listening to and honoring somatic cues. And this is a lot of times just learning your hunger fullness. Of course, with having an eating disorder, hunger fullness can be very altered. And it's not always, You may not definitely teach any type of intuitive eating to somebody who's still in a restrictive phase of their eating disorder. It may be much more where you would teach it to somebody who has given themselves permission to eat, and they're more worried about, maybe they have some history or experience of binging or purging, and but they have that experience of permission to eat. So I just want to preface that so you know that that is important. So this one, though, is something that I've taught to patients who kind of lack a little bit of the hunger cue stomach-wise, and it would be more of attention. So if somebody were to ask, hey, do you want food? And their first reaction would be like, no, I'm okay, thanks. And then they look at it, the food again, so their attention goes to the food to be able to accept the food. So it's where my attention goes, paying attention to attention and knowing that if I look at that food twice, I might be hungry, and to accept that. So it is just a way to kind of help them with that. Challenges and extras. So this is more what we do in a setting like this, but it would be where we have challenges would be like Whoppers and candy bars and cookies and stuff like that. And then extra is just extra food, like whatever's being served. But one of the things we'll do is, and some of this is to help people voice that they are hungry or they want more food. So for some people, they're not going to want to necessarily say, hey, I'm hungry. That might be a big deal. That might be an assignment to say, I'm hungry, or can I have that? Or I'd like to go eat. To even say that is important. Whether they get food or not, that might be the first step. It's all right. And then with the challenges and extras, it might be getting that food, whether they eat it or not, but to ask for more could be what you're working on with them. And it would be recognizing and honoring wants and somatic cues. And sometimes it's just an assignment to be able to ask or to be able to state that you're hungry. So some more things with listening to and honoring somatic cues. And you probably already know a lot about hunger and fullness monitoring. I'm going to tell you one way that I'd like to teach some people with fullness. So some people may, and it also has to do with attention. So some people may not recognize fullness stomach-wise. They might kind of miss some of those things, but it would be having all the food plated, right? And then you eat according to your attention and what tastes good. And so a very, very subtle place might be where you taste food and it's a little cold, or it's a little salty, or you're getting a little bit more critical of your food. It doesn't taste as good. So it's following your attention around the plate. That might be a really subtle place for somebody to stop, but it's paying attention to that attention. And they maybe want something sweet, but it's just kind of a little different way of looking at it. Mirrored eating, I've done a fair amount, and that is where I'll go out with a patient, we'll get the exact same food, and I will eat the food just like they are. And I will tell them, okay, I'm noticing this in my body. Do you notice anything? So it might be like I notice a little bit of pressure in my stomach, and the stomach would be like right where, the ribs kind of come up, more in that area, higher up. And you ask them, okay, what are you noticing? And with fullness, I had one. So you want to say, ask, where do you feel fullness? Because you'll have sometimes patients will be like, I'm full. And you'll be like, well, where do you feel that? And I had one patient say, I feel it in my cheeks and my thighs. I'm like, well, that's probably not actually a somatic cue of fullness. So make sure you ask them. Mirrored eating can also be used sometimes when you have somebody playing a lot of food games, and you can do those same types of things they're doing and then ask, okay, well, is there anything you're noticing with me? And so you're just kind of mirroring how they do stuff, and so that they can have a little bit different experience, or you're also verbalizing what's happening with your body. Another one I've done is with it, and this is more of just something to pay attention to, but it's with screens. So here and there, you'll have people who will cope by eating and watching stuff online. And so there is so much, I've had some patients where I'm like, hey, why don't we just eat and without any screens? And I've had some of them say like, why bother eating then? And so, my thought is maybe there is so much input because you're hearing things, you're seeing things, you're tasting things, you got all this sensation happening, and it's numbing. And it just is a more self-soothing type of a thing. And so we'll kind of chat about that. But here and there, if you have somebody who copes by eating and watching stuff, that is something to be aware of, and then also see, okay, can we do this differently? And you could do it. You could just offer assignments and experiences that would help. And as I mentioned, is possibly overloading the sensations that can create numbing. So one of the things also I want to pay attention to is how to not make amends. And I will have this be where, we kind of look at it like with purging or with exercise or with restricting, how to fix what they did or what we did or however you want to say it. But, sometimes what I will say is, okay, so you got a little full, you got a little over full. It's not like you did anything wrong. It's not a mistake. And so here and there, it'll be like, well, I have to binge and purge, or I have to binge because I crossed a line. I did something wrong. I made a mistake. And so one of the ways that'll kind of help patients with that idea is that, okay, well, it's like a parking meter. So you put in 50 cents, 2 quarters instead of 35 cents. It just means you have more time and there's nothing wrong. And that's usually somewhat helpful because we want to make sure that it is usually where that making amends is, it feels like I've messed up. I've done something wrong. And there is a lot of that, self-soothing, important things that are kind of really important to teach patients of how to remain kind of grounded and okay. And even though it's a stomach, maybe I'm too full, maybe it's head-wise, they know how many calories they ate, and it should be, it's something they feel like they have to fix. But to know it's okay. You don't have to fix this. There's nothing wrong. You've not made any mistake. And it's okay to just kind of pick it up after that as opposed to fix it. Because that does tend to, that will tend to mess up a lot of the experiences you're doing if they are fixing it. Because the eating disorder, if we think of personifying the eating disorder, it would be like, okay, well, the only reason you're okay is because you threw up, or the only reason you're okay is because you ran for 2 hours. And so we need to be able to have these experiences and normalize these experiences food wise, but also not have it be where the eating disorder steps in and says, you're only okay because of me, right? So we don't want to have to feel like people have to purge in order to clean the slate. And it is, I think that how do we allow ourselves to make mistakes and keep moving forward? And I really do say, okay, there isn't a right or wrong. There isn't a mistake. We always kind of learn from all sorts of things. And if there's something that we can kind of pay attention to, and okay, well, what did I learn in this situation? It is really helpful. I think also the other one I'm thinking of with this is when we have patients who might eat for emotions. And I do think that sometimes that can be it's a really challenging thing to have them work through. But I always say with patients, you can have aha moments. And if you do something a little bit different than you would have done when you had, you were in the thick of your eating disorder, sometimes they make a huge difference overall, right? So say if we have, I'm thinking of a patient who they're in Walmart and they wanted to go buy a bunch of cookies. So instead of getting the cookies, and more ask themselves, okay, what is it that's bothering me? Because they knew, okay, I'm not really hungry, but they were overwhelmed with the amount of people and the amount of stuff happening around them. And so instead of getting the cookies, they went outside and just kind of took some deep breaths or came back at a different time. No, I can't actually remember what they did, but changing things a little bit different and putting some pause and some awareness of what is happening and why do I want to do this made a huge difference, right? Because then the next time they're like, I'm going to go buy a bunch of donuts. They can say, okay, what's bothering me, right? And that is just that paying attention to what's going on. How do I do it different? And here and there, I'll also say for some people, a lot of these things that we're doing are like throwing a little pebble in a pond, right? So it's like a little rock goes into the water, and then there's a little circle that comes out from that rock, and it just could distribute throughout the entire pond. So it's a tiny thing, but over time it can make a big difference. It can just gradually move out. And then the experience of life and food can be quite different. Exercising as well. One of the things I do like to say, that must be my thumb, sorry about that. One of the things I do like to say with exercise is that exercise isn't bad, but it would be like brushing your teeth. If you brush your teeth too much, then it's really bad for your gums, right? Or your dentist is going to get mad at you. And if you don't brush your teeth at all, that's a problem too. So exercise is very much like that. There's a middle ground. I also do think a lot of times with exercise, if it's done and it's not something somebody really enjoys, then it can be a problem. It would be like food. You're eating food that would be just not something you enjoy or feel pleasure eating. And it could be like that with exercise, where you're just doing it because you feel like you have to. Well, that's not very pleasurable. There might be some other type of movement that you just kind of enjoy and makes a big difference in your life. But don't do it to fix stuff or fix your food. Laxatives too, there's just no point with those types of things. Okay, so we want to definitely, with all of our experiences, support patients in the trenches. I like experiences way more than just talking about what we're doing. Well, I like to do it. It does make a big difference. And some of it is the preparation, and then you also want to make sure you process the experience. But we really only need to do things that the patients want to do. Here and there, it'll be an assignment if they're really stuck in a restrictive phase. it's an assignment, but you can find ways that it would make sense to them to do it. And here and there, it's just, let's just do it and see how you feel and see what it's like for you. They may also say, oh, I don't, I don't have a problem with that. It'd be fine. I can totally ask for food. I can say I'm hungry. But we might say, okay, well, just try it out and see. Try it out and see how it goes. And they can practice with you as well. Even just that, saying I'm hungry to you, even if they're not, but to get those words out might be a big deal for them. And then processing and repeating. I would say also repeat experiences. That's super important. So, and with all of this, mainly what we're doing is we want to help patients give themselves permission to eat. And then also permission to not eat, to say, no, I'm okay, or thank you, I'm full, or whatever it is. But as long as they're really honoring their bodies, they're taking care of themselves, they're doing what feels good, that's, not hurting them, whatever it is really, I always think it is their body, it's their life, it's their recovery. I'll help them however possible, and then also kind of be with them at the same time, to kind of talk them through certain experiences. And then I also want to kind of talk about that not making amends, not fixing it. So the eating disorder says, you need me. So I think we may have ended a little early. So hopefully you do have some questions. I think we're about 5 minutes earlier than I had planned.
You're good, Rebekah. We have tons of questions. So your timing is just fine. Excuse me. Before we get to questions though, let me just go over a couple of quick housekeeping things. We know we have lots of clinicians on and may have to hop off at the top of the hour. So just a reminder that when I stop the webinar, or if you leave the webinar, in the same screen where you're looking now, there will be an evaluation, a webinar evaluation that will pop up on that same screen. If you'd be so kind as to take just 30 seconds or so to complete that, that would be really helpful. That's a continuing education requirement for us. It's completely anonymous, so feel free to be candid in your feedback. We tabulate those results and then are required to send those to the CE approval folks. So if you could do that, that'd be great. And then also when I stop the webinar, or if you leave, the link to take the post test for continuing education credit will pop up in a separate tab. For those of you on a desktop or a laptop, you likely will easily see that. For those of you folks who are on your phone or on a tablet, it may be buried at the very end of your tabs. All your tabs that are open, it'll be there somewhere. So search for it. Once you find that, then take the test online. When you pass the test on the testing site, your CE certificate will be available for download there on that site. So look for that. It doesn't come from Center for Change. It's available there on ClassMarker after you finish the test and pass it. All right, Rebekah, let me get back to my questions. We have tons. Sorry, go ahead.
You want me to stop sharing?
Yes, please. That's great. Either way. Perfect. Okay. Okay, the first question comes from, and I'll get to as many as I can. And then if you have a burning question that we don't get to, that you absolutely have to know, feel free to send an email to me at cfcwebinar@gmail.com. It's the same email address that's on all your correspondence that you get about the webinar. Again, it's cfcwebinar@gmail.com. You can email me and I'll pass it along to Rebekah, because we definitely won't be able to get to all the questions today. Okay, here we go. This is from Megan. I work in a PHP where I come up with a lot of ideas like this, but then the clients reject them and say they won't do them. How do you challenge clients to do these interventions?
Well, with some of them, especially with the PHP, if you can have, I don't know exactly if you have levels or anything, but if you have different levels or phases where they have to do certain things in order to progress, we do have that with some of our patients who restrict a lot, to where it's like you have to ask for an extra and eat 50% in order to go on to another phase. So it could be, if you can tie it to different things they want, that can be helpful. Because you will have some patients where they're like, I'm not doing that. So, and then I would also try to take baby steps where it's just like, let's do a little thing, you know, something that's maybe not the full thing.
Got it. Thank you. Next question is from Brooke. Brooke says, what interventions do you use if someone struggles to identify hunger cues and or feels sick after eating, or if they eat too early or too late? So they're uncomfortable.
Okay. So with hunger cues, like I'll say, if you have a lot of anxiety or you have some bigger type of sensations, then those are going to trump hunger fullness a lot. And so it depends on the person. There's also a little bit with OCD where it is an internal sensation where they feel a lot of sensations really deeply. And so here and there, you'll have a patient where little tiny internal sensations feel huge. So if they are uncomfortable, that could be that. That could also be that they're getting themselves upset. So to kind of separate, okay, let me stay really calm, let me breathe, let me see if I can figure this out. And then there's also some people who don't feel like they've kind of cut themselves off from the neck down. And I'll ask them, okay, is there any time you ever feel your body? Like I had one person who, it was maybe in the morning with their sheets, that felt like a safe place to feel their body, or it was when they would kind of lie on a rock. So a harder thing. So it's kind of like, okay, can I start increasing my ability to sense my body from my neck down? So you have to get a little bit creative, and there could be a variety of different things happening.
Thank you. This is from Brooke. How do you challenge clients who struggle getting variety in their diet?
We definitely have that with some of our patients who have ARFID. We usually have to find some reason that they would want to increase their variety. A lot of times, they can be pretty healthy their whole lives without eating a lot of different things. And so that's okay. But if there are certain things that they would like to try because it helps in social situations, they're more likely to do it. But it would be like anyone. And you can tell them, it's even little kids, they have to first have it in front of them and have it like in front of them like 10 times in order to ever start seeing it as not terrible or bad. Or so it depends on why they're not getting variety, but it's repetition, and it's if they want to.
Thank you. Kendra asks, what would be a helpful intervention for a patient with anorexia who does not seem to gain pleasure from food? That's a big question.
Yeah. I think sometimes it's the bigger picture of why, because oftentimes they'll also have where it's not okay to feel pleasure at all for other things either. And so oftentimes it's a way more of a therapeutic of a digging deeper as to what makes you feel like it's not okay for you to feel pleasure, or why is that not safe. And so it is way more of a therapeutic type of a thing. Like it can feel like bad and not okay. Yeah. But it's likely not just with food.
Got it. Thank you. Sherry or Cherie, I apologize, I'm not sure which one it is. Could you explain the purpose of plating for a loved one intervention again? I think they just wanted a little more detail about why and what that looks like.
Yes, I was hurrying at first because like
and I did great. So now you can do it again and go slower.
So that had to do more with like some people will cognitively they'll say, well, that's a fat, protein, carbohydrate, or that's a certain thing, and they'll feel like that's enough. But if they were to plate for somebody else, they might make it prettier. They
Yeah.
might add some color. If it was a kid, they might add a vegetable. So it's not me saying, hey, you need a vegetable because of this or that. It's what they think is appropriate for someone they love. And it tends to be a lot of it's a different way. It tends to be prettier and nice. It's a little bit more balanced because they have some idea of what that person would need or want to make it a good experience. So that's kind of it.
That makes sense. Thank you. We had an anonymous attendee ask, how can you support a patient that is tube dependent but struggles with accepting that?
A lot of times with somebody who's tube dependent, I mean, if and it sounds like they want to not be tube dependent.
Right.
But you know, I will say a lot of times, you know, like if they had cancer, it might be hard to accept. But you kind of do whatever you need to do therapeutic wise to make it where they can do life at the same time. And so with a tube, a lot of times it is they can have a tube but still do life. And even if it feels kind of like they wish it was different, you know, you can kind of work through that where maybe they try certain things here or there. But unfortunately, we don't always get to choose what happens to us in life, and we just do the best we can. So with the tube, it's just you live your life the best way you can. And, you know, I'm sorry that you know, that you wish it was different, but.
Thank you. We'll do this, we're at the top of the hour, so we'll do this as the last question. This is from Shelby. Ideas for clients always comparing what they eat to other people. Quote, they skip meals and don't eat snacks, or no one makes a big deal about that.
Yeah,
We don't ever hear that here.
yeah, it's like I eat more than my family. I'm like, yeah, but they probably eat at other times too. You
Right.
know, so they're comparing to and you'll see that with people with bodies too, where they'll compare to where they feel like it's just not an accurate comparison is what it is. So I would say, okay, well, we always say you just need to worry about your own recovery. It's really what it is because everybody is different. We have very different patients that are doing different things. And just because they do something, I think it's just a human response of,
Right.
I think everyone does that, not just patients, but, a lot of times I'll try to be like, okay, but what sounds good to you? What feels good to you? Is this pleasure for you? Like kind of go back to what you want as opposed to this person's getting away with something and I want to get away with it too. It's more like, wow, is that really what you want? Is that your way out of out of an eating disorder? So I think it's just a human thing. I don't know. I don't know what to say about that.
I think you did great. Thank you. My thanks again to Rebekah for presenting today and to all of you for being here and taking time out of your busy days to be with us. So we much appreciate it. And we hope you join us again. We have another webinar in a couple of months. And actually it's Dr. Reed Robison, our medical director, who's speaking on psychedelics and eating disorders. So it's really an interesting topic. So we hope you all can join us. Watch for emails about that in the coming weeks. And in the meantime, everybody stay well. Take care.